Greetings from Baltimore, Maryland. My name is Mona Bahout. I'm a stroke neurologist. Thank you to the conference organizers for all of the hard work that goes into orchestrating such an excellent educational offering and for the invitation to join you today. I'm excited to spend the next few minutes talking with you about concepts in early brain recovery after stroke, as well as systems innovation that really can take your stroke centers of care to the next level in terms of assuring that we have early recovery activities incorporated into the days of our patients. It's been an exciting few decades to be a stroke neurologist. With the advent of hyperacute therapies, both thrombolysis as well as mechanical thrombectomy and prolonged treatment windows, we certainly have come a long way in terms of the treatment of this disease and reduction of mortality related to disease. Not only have these hyperacute treatments changed the needle of mortality, but also stroke centers of care that standardize our approach to stroke treatment have really provided benefit to patients. As you can see on the map provided here by the World Health Organization, the global picture of stroke, though, remains quite variable, and some regions of the world still have significant work to do in terms of reducing stroke-related mortality. I would state that we all have a lot more work to do, however, because we have not quite moved the needle yet on stroke-related disability. We know that this is a common disease. 15 million people will have strokes per year, and it does remain the second leading cause of death worldwide. But to me, the thing that really needs our undivided attention is that stroke remains the leading cause of adult disability, despite the advent of all of our hyperacute treatments. And this is not just for patients with large territory strokes, but also for patients with milder strokes, so-called milder strokes with NIH stroke scale scores less than 5. The literature reports that about 30% of those patients will still report poor functional outcome at 3 months. So definitely have some work to do. In addition to the disability related to stroke, we certainly know that this disease carries high economic burden, both lost productivity for the patient as well as their care partner that is along in the journey of this disease. And I am excited to talk about the focus of what I believe is the most missed opportunity in this continuum of stroke care. As you can see on this figure, we have made great advances along the entire continuum of stroke care. We certainly have had a lot of studies related to stroke prevention and ways to reduce chance of stroke recurrence. We have spent billions of dollars on the studies of hyperacute therapies that we've been discussing for the last several days together. And certainly there have been rehabilitation studies about chronic care of stroke patients, as well as community integration. How do we get stroke patients successfully back to their homes? But I would say that we're really understudied in the area of very early stroke recovery. What happens in those first few days and weeks after stroke that can really help the patient to recover to the best of their ability? Are we really doing everything that we can in those first few days to optimize the patient's clinical status and influence long-term disability? And why might this early period be very important to the stroke recovery trajectory? Well, animal models have suggested that the first few weeks after stroke are really the sensitive period, the period when the brain may have the most heightened probability of early brain repair. As you can see from the graph here, in animal models, we have demonstrated that in the first couple of weeks after stroke, really 14 days up to 30 days, the brain has upregulation of growth promoting factors, as well as reduction of regulation of growth inhibiting factors, which really means that this is the brain's peak opportunity to repair to the best of its ability. So I would say that what happens in those first couple of days and weeks after stroke really have high impact towards the long-term ability of the brain to repair and us to reduce disability. And this has looked like it's going to translate well to humans. In a study that most recently came out just this summer by Dromerick and colleagues, the critical period after stroke was tested again to see if we could influence the ability of stroke recovery by implementing more intensive upper extremity therapy at different time points after stroke. In this study, they stratified inclusion of patients in both the acute period, subacute period, chronic period against controls in order to determine if this intensive therapy addition would have any benefit. And as you could see, this phase 2 study did demonstrate that implementation of an advanced arm therapy protocol and the acute and subacute periods did yield higher improvement, with their primary objective being arm strength measured by the ARAT. You could see that the most significant gain was in the subacute period, meaning the first 2 months after stroke, but the acute period, meaning implementation within the first month after stroke, also had high yield. There were no benefit to implementing additional therapy for patients in the chronic phase up to 6 months. But the problem is that stroke patients actually who are not enrolled in any research studies are very inactive, and they are not achieving either the activity that are needed for intensive limb therapy nor intensive language recovery therapy. And we have a lot of work to do in terms of the level of inactivity, especially in the acute period. We know that activity and movement are essential to recover from stroke, but because stroke leads to paralysis and cognitive disturbance, that is not always easy to attain in those first couple of days and weeks after stroke. We've just talked about the fact that there is a limited window of opportunity for brain repair, but I would say that the majority of patients spend a majority of that time in the hospital or in a facility where they're not having intensive therapy or treatments for brain repair during that period. We know that bed rest is a problem that persists after stroke. In fact, hospitalized stroke patients have been shown to spend about 65% of their time in bed. And bed rest leads to complications that further cause additional delays to rehab and intensive therapies. This is especially problematic for patients with intracerebral hemorrhage. So the recommendations are that stroke patients receive rehabilitation at an intensity that's commensurate with their anticipated benefit and tolerance in the early period, but this is not always very easy to achieve. Additional studies have really shown also that early activity and early mobilization after stroke may be helpful to stroke patients. So at the top of the table, you can see a chronology of several studies that showed potential benefit to getting patients up and about and mobilizing them in the early period after stroke. They showed improved functional outcome in some studies, reduction in mortality, and certainly reduction in complications related to bed rest. So this was promising to again show that humans require activity after stroke to reduce stroke-related disability. Now that is until the 2015 study by Bernhardt and colleagues, which was the largest multi-center study to look at very early mobility after stroke. And to some people's surprise, this study demonstrated worse functional outcome based on the modified Rankin in the very early mobilization group. This caused pause in the group who were trying to talk about early mobilization and early treatment and activity after stroke, and really made us rethink our practices in the very early period. But this takes a little closer look before we completely stop mobilizing patients in the early treatment. The AVERT trial stratified patients into different levels of functioning and arousal and titrated their sessions of activity based on those levels. It was a large study. They recruited 2,100 patients across the globe in a multi-center study, but again, they demonstrated reduced odds of good 3-month functional outcome in the patients who were mobilized within the first 24 hours after stroke onset. Now, before applying this to all patients, we have to look at the doses that were given and what was the problem in this study. And I would point out on this slide that the real issue is that if you look at this line item here, the duration of out-of-bed sessions, the total number of minutes that a person actually had mobilization out of bed was on average 18 minutes per day. That is not significant in a 24-hour clock. But what was significant was these patients who are out of bed in the very early period had a significantly different blood pressure reduction related to out-of-bed activities related to the controls. And this really warrants additional attention by us as stroke specialists. So why does blood pressure matter? Just to pause into a bit of physiologic review of why it's critical for us to consider blood pressure, especially in these large trials, as a really important variable in early stroke care. On this graph, this is a reminder about the relationship between cerebral blood flow and mean blood pressure in a period after stroke when autoregulation is completely impaired. You can see here that in normal times, we are constantly protecting our brain from fluctuations in blood pressure. when we have high blood pressure because of sudden stress or a sneeze or something that causes a Valsalva to increase potential systemic blood pressure, our brain responds swiftly by vasoconstricting and protecting the brain from additional cerebral blood flow. Additionally, if we drop our blood pressure suddenly, there is a rapid vasodilation that will protect our brain and assure that cerebral blood flow remains fairly constant. On this graph, though, is the dotted line that shows what happens when autoregulation is impaired. Here you can see that the brain becomes exactly vulnerable to whatever the systemic blood pressure is, reminding us then that as stroke providers, we become autoregulation for that patient in the first days and weeks after stroke until those autoregulatory systems can resume. Now, what happens when autoregulation is impaired and we become have complications because we're directly related to the blood pressures that we're having? If our blood pressure is high, we can see here on the top of this graph that this will result in hemorrhagic transformation or the rapid development of cerebral edema. If our blood pressure drops, and we know that stroke patients often have dysautonomia and orthostatic hypotension in the early period, if our blood pressure drops, this can lead to secondary ischemia or additional infarct. And for that reason, we pay very close attention to hemodynamics after stroke, especially when we're thinking of the concept of introducing new activity or exercise after stroke. And I believe this was a core concept as we consider the data presented from the AVERT trial. This should not stop us from wanting to increase activity for our patients in the early period, but it really underscores that we have to take these concepts into consideration as we're considering our activity protocols that we implement. And activity in the early stroke period is not just complicated by blood pressure management and hemodynamics. We certainly know that blood pressure lability is key and really needs our focused attention in those first few days and weeks, because we really don't want to lead to additional territory of infarct or additional hemorrhagic transformation. But there are other complexities that really interfere with incorporating activity programs in the early period. One is that hemiplegia is very common, and this requires staff who are quite expert in helping patients to safely move under these conditions. We have to have enough resources in terms of staff, as well as be cautious about staff injury. We also know that our stroke patients are frail at the onset of their stroke symptoms. They're often deconditioned in terms of cardiovascular status and often deconditioned in general in terms of muscle strength and activity tolerance. So as we're designing our early activity programs, we really need to take that into consideration. The next feature is fatigue. Stroke patients have fatigue 80% of the time from the stroke alone. The brain is repairing. It takes a lot of energy for these restorative structures to come into play. And fatigue really interferes with the ability to endure therapy sessions. So as we're making protocols for early stroke therapy, we'll need to take fatigue into account. We know stroke patients are at risk for falls. The only way to really stop falls are to keep people in bed. And so we have to balance the risk of falls with the the benefit of reducing complications after stroke, especially in patients who may be impulsive or having hemispatial neglect related to the location of their ischemia. And then finally, many patients come to the hospital with mild cognitive impairment at baseline that is only worsened by the stroke or the presence of hospital-related delirium. So assuring that we have a safe protocol for patients with altered cognitive status is key. And often these patients were excluded from some of the trials, so it really requires some specific planning from your staff's part as you're creating your advanced activity planning for your stroke patients. But we really think that the solution is to promote early activity after stroke, but with the assembly of a very thoughtful team of people to consider how you're going to titrate early activity using established protocols, how you're going to support the patient and staff to make sure we get the right tools to help. How are we going to motivate the patient so that they can endure during therapy, especially at a time when they have high levels of fatigue? How will we monitor those patients to assure that the therapies that we're delivering are actually helpful and not harmful to the patient who we have in front of us? And we have to have the ability to both standardize our approach to care, but pivot and modify for individual factors that may emerge as we look at the physiologic response to some of those therapies. So one critical thing that we've done here at the Johns Hopkins Hospital was assure that we had an activity and mobility algorithm. We wanted to be sure that our progressive activity plan did not simply rely on physiotherapists, but also could incorporate any level of the clinical team. So this algorithm, developed by Betsy Zink in the Neurocritical Care Unit with a collaborative team of interdisciplinary providers, really demonstrates how to assure that everybody, bedside RNs through the therapy group, are using a standard approach to progressive mobilization. Very few patients are excluded from this algorithm, only patients with potential safety issues of spinal cord instability or severe coma for which mobility may be harmful, or patients with uncontrolled intracranial hypertension. Patients are put into an active mobilization group if they don't have any of those exclusions, and it's basically a progressive plan, taking someone safely from bed rest to slowly elevating out of bed to walking eventually. This is something that every staff member should try to progress step forward. And there are specific stopping rules that are in clear definition to assure that patients have ability to modify our activity plan if we start seeing any complications. If somebody has early problems with severe coma, we do passive mobilization until they're ready to go into the progressive active mobilization arm. And this has really yielded a really important change in terms of our neurocritical care unit. We basically tripled the number of times patients were mobilized in the ICU after admission for intracerebral hemorrhage, which was our most difficult population, and has been very high yield in terms of expanding and including RNs, therapists, and physicians in terms of the mobility and activity program. And so standardization was a critical first step. We also have had to really look at the tools that we had available to assure that we could meet the needs of all of our patients. On this montage, I am just showing you a series of tools that we've had that really help patients who are both comatose to keep the sort of limbs moving safely. This is a patient who's ventilated and not able to provide any input to his own activity, but comatose. This allows his legs to be moved in a passive format. The cycle really allows both passive movement, and once the patient starts engaging with the cycle, transfers over to active movement. This device can be used for upper extremity training as well, and we have all kinds of tools to go from bed rest to progressively verticalized to make sure that the patient can progress systematically through our mobility algorithm. All the while, we want to really assure that hemodynamics are closely monitored and that the patient is responding as we'd hope to make sure brain perfusion is optimized. Here is some data that looked at our response to exercise in the early period. We wanted to first make sure that blood pressure and ICPs were not affected when we started implementing some of these tools. And you can see here that our graphs show that pre and post cycling, there was essentially no change between groups. And even in patients with ICP issues, there were really no changes in ICP management and external ventricular drains. So some of our physiologic responses to cycloergometer really have shown to be very safe. We've also created protocols that assure standardization of how we use these tools. And here's one example from one of our occupational therapists who really devised this algorithm to assure that everybody's using the tools properly and protecting the upper limb from any complications that can occur from both passive and active exercise. And as you can see here, the device can be used upright, sitting in the chair, to kind of assure both passive and active arm movement in the early period. And again, upper extremity cycling, we wanted to double check that there were no hemodynamic or physiologic alterations related to use of the upper extremity cycle. And here you can see on this graph, as we demonstrated, there were really no change in ICP before and after therapy. So some of our concerns of safety of some of these devices have really been reassured by some of these data. So that has been a helpful start, but I would say that the future in early stroke recovery is only in its infancy, and the future is quite bright. These are the concepts that we're really focusing on in terms of our mission at this stage in promoting early stroke recovery for hospitalized stroke patients. We really want to make sure that we can start restorative therapies in the early period and with much more consistency throughout the day. We know that the hospital is a busy place for patients, but we think that we can really structure our system of care to incorporate many more treatment therapies for both impairment and functional recovery in the first days and weeks after stroke. We believe that unless we motivate the patient to engage in high quality and high intensity activity, we'll have missed the boat. We know from research that people don't just need a little bit of therapy, they actually need many repetitions and high intensity therapy. So how to get the patient to do that at a time where they're tired and have a lot of distractions is really, really a key factor. We need to find better tools to measure the patient's response in real time, the physiologic responses to early activity, so that we can better titrate some of our treatment algorithms. And we need to make sure to personalize our treatment plans in real time based on the data that we're seeing. So teaching people the thresholds of go, no go in terms of continuing exercise are going to be critical. And our major approach to this has been really looking at gamification in the early stroke period. Can we make the hospital a little bit more fun so that patients can engage in their therapy and sustain with it actually for prolonged periods so they can have more repetitions and more intensity with the therapies that we're offering? Years ago, we started with a very low cost project where we looked to see if anybody would like to donate their Wii device to the hospital. All the nurses and doctors took their old Wiis that had not been used for years. And one of our therapists, Megan Ziegler, created this algorithm of which games could possibly help with certain stroke-related deficits. So if a patient has coordination problems, perhaps the bowling and boxing games would be best for that patient. And we used this algorithm to try to standardize our approach to patients as they were starting to progress through their algorithm. Here's a picture of an intubated patient in the neuro ICU who was being supported by one of the therapists, but in the middle of a boxing game to work on some of her deficits. And really, we believe that if we can motivate the patient to sort of participate with more fun and more energy, perhaps we'll get longer durations of treatment sessions and higher repetitions in the early period. And here we see that our patients really were able to use these games, the Wii device, in the very early period, even if they were had ventilators, they had external ventricular devices, tracheostomy, all of whom they were able to really endure during these games. The highest indication when people pulled the games out were for balance and coordination, but obviously activity and endurance and cognitive stimulation were high on the list as well. And a particular story that sticks with us is a patient with severe hemispatial neglect using one of the boxing games was able to really attend to that neglected limb much more so after the therapy session using the gaming approach. So we thought it was a very low cost method of starting our gamification of post-stroke care. We have moved now, though, into a more immersive environment where we're using digital therapeutics to both change the environment around the stroke patient, as well as help the patient to really perform high intensity, high quality movements, perhaps without even knowing that they're doing it. Here we have a picture of our immersive therapy room that includes the MindPod approach to care. In this system, there is a beautiful ocean environment created around the patient, and the patient is with a tracker monitored, and limb movement causes a cute dolphin who is there to heal the patient to swim around in the ocean environment. It's a game that allows the arm to become the movement of the dolphin, and the dolphin also has to perform in that area to kind of escape sharks and avoid complications. The dolphin can jump and swim, and it really transports the patient from a hospital environment into a place where beautiful music and beautiful environment around them make the minutes just wash away with upper extremity movement so that the patient can get much more high intensity, high quality movement. This was stimulated and initiated by the John Krakauer lab, and that we have been working closely with the Kata group of engineers and artists to really assure that we can create this environment with the highest pleasure and intensity. Now, all of this to say that we have a lot of work to do. But we think that the future is really bright and that we are on the verge of creating what I like to call the stroke unit of the near future. This is a space that both motivates, measures, and promotes recovery from the minute the patient lands in the stroke unit. We picture a day where a patient comes to a high technology room where hemodynamics are monitored and can closely interact with sort of the digital therapeutic systems that we are creating over time. Wouldn't it be lovely if this whole environment became focused around the patient and the patient's responses and the patient's need to both promote early activity if the patient is on too much bed rest or not having enough activity, or helping to create a calming space if there is alteration in the hemodynamics. So we really see this innovation in our stroke center as the stroke unit of the future so that we can help patients recover more effectively in the early period. This room would really contain all of the features that we've talked about. The digital therapeutic system, which could come on the patient's schedule instead of requiring scheduling with the therapist or other people. It will almost be a form of auto rehabilitation, in that when the patient is awake and ready to engage in some activity, they could activate the digital therapeutic system right from their bed or their chair, and the room would transform into this oceanic scene so that the patient can start some additional therapy. We want to make sure that the patient can do self-management and know their goals so that they can work to attain it both with their care partners and with their own motivation during the day. It's an environment that would be, we have been measuring hemodynamics during it with various monitors to really see how the cardiac output and hemodynamics are changing during activity so that we can either increase the intensity of activity if the patient can tolerate or decrease if it becomes too much and exceeds the cardiovascular reserve. We're finding measures that can tell us, is this thing really mattering for the patient? Can we measure with various measurement tools how gait speed is changing or strength is changing so that we can really be objective in our opinion about whether or not these systems are helping or hurting. This will allow for dose changes as well as helping to really decide what the best timing should be in terms of intensity and duration. And over the next couple of years, we're going to have a lot of data from these spaces, both in the patient's hospital room, as well as in our immersive treatment rooms, to find out just how to incorporate these activities into the patient's day from day one after hospitalization. So in summary, time is critical in stroke management. We know that for hyperacute treatments, but what happens in the first few days and weeks, I think, are equally or maybe even more important to the patient. These approaches to care will really reach all stroke patients without bias of what time they arrive to the hospital and really help us to try to move the needle on stroke-related disability. Really, teamwork is critical. We need specialized care with multiple disciplines to coordinate activity in the first few days after stroke so that we can reduce complications and really expedite brain repair at a time that we have a sensitive window of opportunity. We can't let a single day go by. Early activity has to be guided by physiologic response to be sure that all of our activities are safe for that particular patient and that we achieve our maximal intensity as long as the patient can tolerate it. And we won't stop until we eliminate stroke-related disability. We have a lot of work to do, and it's a very exciting time to work together on this problem until we find a perfect solution. So I can't have this talk without acknowledging our tremendous team who have all been vigilantly working on this problem together over the last few years. I couldn't possibly name everybody on this, but I could tell you I feel lucky to work with the best interprofessional team across the globe. And I look forward to talking with you more through both email and during the live discussion section. And I really thank you for your attention. Here are some references and my email address in case you would like to interact with me after the session. Thank you for your time.